Thank you for joining. We will begin shortly. Thank you for joining. Please enjoy the event.
Welcome. I am Jean Lamprou, the Director of Healthcare Reform and a Senior Fellow at the Century Foundation, a progressive, nonpartisan think tank. I am here in a gray room and wearing a tan shirt with a black necklace. Thank you for joining the discussion of how states can promote health equity while lowering healthcare costs. The starting point for this conversation is that excessively high prices charged by healthcare providers and paid by both people and insurance not only harm this economy, but worsen health disparities. The Century Foundation, led by our healthcare policy fellow, Thomas Waldrop, has issued a series of reports with practical ideas to tackle health disparities and costs. Those reports can be found on our website, tcf.org. Thomas will shortly present those findings and moderate a discussion with an excellent panel of experts, policymakers, and advocates. You will have a chance to submit questions for discussion by using the chat feature. This hour-long event is being recorded and live-streamed. Before turning over to Thomas, I want to thank Arnold Ventures for supporting this work. With that, I welcome Hunter Kellett, the Director of Commercial Prices, to say a few words.
Thank you so much, Jean. My name is Hunter Kellett. I'm a director at Arnold Ventures. I'm sitting here in a white office with glasses. Arnold Ventures is a philanthropic organization aimed at addressing some of the nation's toughest problems, including the rising cost of healthcare in this country. For people with commercial insurance, rising premiums and out-of-pocket costs can make maintaining and using that coverage financially challenging. People with insurance skip necessary care, avoid going to the doctor, avoid filling prescriptions, or even walking into an emergency room out of fear of the bill that they will receive. Today, we know over 100 million Americans have some form of medical debt, which disproportionately impacts minority populations, women, and parents. A recent KFF study found new mothers were twice as likely to have medical debt than those who had not given birth. We know for those with debt, 6 in 10 say they're cutting back on basic necessities, things like food and clothing. 4 in 10 with debt have taken on an extra job to help pay for it, and 2 in 10 with debt have had to move and now live with family and friends. Lowering cost is critical for protecting people from the financial burden placed on them by the healthcare system. And we at Arnold Ventures partnered with the Century Foundation to create resources for states and to support states as they explore options for both lowering costs and promoting equity. And what we've seen is that states can do both, but it is very critical that that process start early, at the beginning of the policy development process, and not as an afterthought. Thank you for attending today's event, and I look forward to the discussion.
Thanks, Hunter. Like Jean said, I am here to present on our report series, and we're really excited to do so. Just waiting on the slideshow to get started, and then we can jump right in. Thanks. Yeah, so just a quick overview. We've already done the welcome, and so we're going to start with a little bit of background on healthcare prices and how that impacts health equity, as well as go through the 4 reports. And then we've got a really exciting panel discussion planned with some great speakers. We've got Secretary Cody Kinsley from the North Carolina Department of Health and Human Services, Isabel Cruz, who's the Policy Director of the Colorado Consumer Health Initiative, and Heather Howard, who's the Director of State Health and Value Strategies at Princeton University, and also a TCF board member. After that, we'll go into an audience Q&A, depending on time and if there's questions. Next slide, please. Yep, and there's the panelists again. Next slide. And next slide, please. So like Jean and Hunter have said, you know, the work we did here was really looking at how healthcare prices and healthcare costs impact health equity. And so, you know, one of the core things we just want to set up here is how, you know, yes, healthcare is unaffordable for everybody, but it's really clear that the burden of high price healthcare doesn't fall on everyone the same. You know, on the left, we've got some data showing, you know, Hispanic and Black patients are more likely to skip the healthcare they need than white patients. You know, patients in worse health are more likely to skip care than patients in good health, and then uninsured patients, understandably, are significantly more likely to skip care than insured patients. Then this trickles into, you know, households' finances as well. On the right, we've got a chart showing, you know, medical debt held by, you know, race and ethnicity. And as you can see, you know, Black and Hispanic patients are much more likely to hold medical debt than their white peers. Next slide, please. And so the first report we did was on the growth in healthcare. And so, you know, the root of this is that healthcare is both really expensive, but also the amount, or the price is growing far too quickly. On the left, you can see, you know, the change in per capita healthcare spending split out by private coverage, Medicare, and Medicaid. And while it's grown for every population, you know, it really has been concentrated in the commercial market, which also covers, you know, about half of the country. So it's a really broad issue that, you know, it needs a solution. And this also trickles into not only, you know, patients out of pocket, but insurance premiums. Shown on the right, there's been a really steady increase in premiums and out of pocket spending across households. Next slide, please. And so, yeah, this first report was looking at how states can do cost growth benchmarks to slow down the growth of health spending. Basically, what these are is, you know, a state sets a goal of, you know, by this time next year, we want our overall health spending to have only grown by this percentage. And around 10 states have done these since 2012, starting with Massachusetts, but, you know, 9 others, including Rhode Island and Delaware. And a few of these states have really shown success in slowing down the cost, or the rate at which healthcare spending increases. And then on the right, we've got a chart or a graphic from the report that we think was really helpful in kind of framing the idea of how to embed equity into cost growth benchmarks. And at the core of that, in the center there, is accountability to marginalized communities. You know, that really should be informing every other step of this. You know, it's not a thing you do at the beginning. It's not something you check off at the end, but it should be baked into every part of that. And so, you know, we view it as a little bit of a cycle, but you've got to start somewhere. And so we think collecting trusted, disaggregated data on spending is the best way to start. You know, you've really got to understand what's being spent, who is it being spent on, how is it growing before you can start to tackle the problem. Going from there, you need to address the historic inequities in healthcare spending. Looking at, majority Black hospitals may have received significantly lower rates from insurers. Other hospitals might have been receiving too much money. And so it's not necessarily just an across the board cut, but it's sort of a realignment of values. From there, you need to, whatever agency the state has charged with this benchmark needs to have some way to actually enforce it, right? If there's not a meaningful way to say, like, hospital X, you have to do this, it's not really a benchmark, it's just a goal. And then finally, the last step from this report is continuous evaluation. All of this work that you've done before is really helpful, but if in a year or two you realize it hasn't actually done anything, then it's not really meeting the goal. It's not improving equity. It's not lowering prices. And this evaluation, again, needs to center accountability to marginalized communities, making sure that both spending is going down, but also that you're not inadvertently creating some sort of disparity in access or affordability. Next slide, please. So the second report in this series addresses consolidation in the healthcare market. Healthcare consolidation has skyrocketed recently, with the overall number of hospitals dropping from around 8,000 in the late 90s to just over 6,000 in 2021. Hospitals have also purchased a significant amount of physician practices, with more than half of all physicians being employed by hospitals as of 2022. And as you can see on the map on the left, there is nowhere in the country that concentration isn't a problem. And for most of the country, their hospital market is significantly very concentrated. And then on the right, just showing the amount of physician practices employed by hospitals. And this market consolidation has real impacts for patients. It drives up the cost of care. It makes it harder to get the healthcare you need. And there's really no evidence that it meaningfully improves the quality of care that people get. And even beyond the price impacts, this consolidation can really impinge access in other ways too. For example, when hospitals are purchased by Catholic health systems, they become subject to morality clauses, and as a result, impose restrictions on access to abortion care, contraception, or gender affirming care. Next slide, please. And so the policy solution here is merger review laws. A good amount of the state has some sort of advanced merger review laws, as you can see on the right there. And basically what these are is, some sort of requirement that before you can buy or sell a hospital, you've got to let somebody in the state know. Usually that's the attorney general, but it's not always. And states, have really varied in whether their requirement is just, hey, you have to let us know first, versus, you can see quite a few states there in the dark blue have a actual approval requirement where before you can go through with that transaction, the state has to approve it. And so the way that states can do this in a way that not only, lowers prices, but also advances equity is first explicitly say that equity is something that, that attorney general or other state official should be reviewing transactions on. If the only concern is prices and there's no evidence that it's going to, raise the cost of an MRI, a state might have to approve it. But if equity is built in, for example, with that Catholic hospital system, that can be a thing to say, well, hey, let's take a step for a moment before we approve this. Similarly to the previous reports, you need enforcement authority, right? All of those green states on that map, they have a notice requirement, but they don't necessarily have any way to jump in and say, you can't sell that hospital, you can't buy that hospital. Following up on this, again, reporting on the impacts of a merger. If an attorney general does say, okay, sure, we'll let you buy this hospital, we'll let you buy this physician practice, require them to, report on how have their prices changed, how has their patient mix changed, what services are they offering. And then finally, the states need to address the existing consolidation. As we saw on the previous slide, much of the country is really, really heavily consolidated already. And so this can happen in a variety of ways. One way is to reform the community benefit requirements that nonprofit hospitals have to provide. The idea is if you're a nonprofit, you should be benefiting the community in some way. Other options that states have are reforming contracting law, reducing hospitals' market power so that one really big hospital can't say, well, you just got to take our prices, or you can't network with our competitors. There's a lot more detail in the reports, but this is kind of the high level. Next slide, please. The next report is looking at hospital prices, or the variation in hospital prices. Right here we've got a chart showing the same knee and hip surgeries. The price for that can vary wildly, even across the same metro area. In the New York metro area, the upper limit there is around 70,000. The lower amount is around 25,000, and this variation doesn't necessarily take into account the quality differences, right? If you're getting better quality care, it probably makes sense to pay more, but that's not really the case. Hospitals often just charge as much as they can. And so the policy solution in this report is reference pricing, where a state or a payer like an insurer says we're not going to pay any more than this amount for this healthcare service. And so if a healthcare provider doesn't agree to that price, they're either removed from the network, or they might have to bill patients for the difference. And other states have adopted this practice as well, usually for state employees. For example, California adopted a variety of reference pricing for a variety of services for their public employee and retiree program. And when they did, they saw a really meaningful difference in the amount paid, but also in where patients were going. There were some hospitals that didn't accept the new rate, and pretty quickly the patients said, oh, well, if I'm going to have to pay a bunch of money, I'm just not going to go there. I'm going to go to this hospital that is also just as good, that isn't going to charge me a bunch of money. Next slide, please. And this chart on the right kind of shows the impact that California's program had. As you can see there, in 2010, after they implemented the program, pretty quickly those higher priced hospitals started lowering their prices to being much more in line with the lower price and with the reference price. And so the way that states can bake equity into these programs, as ever, is starting by collecting accurate data. You need to know where or who's getting charged what, and what the variation is. The next portion is establishing equitable reference rates. They need to keep in mind how dropping a price super quickly might impact patient access. For example, a rural hospital might be the only hospital in the area, and it might need some sort of policy solution to address the burden of high prices without really reducing access. What the reference rate is also really important for ensuring provider participation. It doesn't do a lot of good to say we're only going to pay $30,000 for this surgery if that means no one in your network will take your money for that surgery anymore, right? And so one way to do this is through the way Oregon did. They adopted it for their public employees as well. And the way they did that was they said, hey, if you're an in-network provider, we're going to pay you no more than 200% of what Medicare pays, or whatever we were paying before, whichever is lower, I believe. But out-of-network providers were capped at 180%. And so in both of these instances, the state was still helping pay for patients' needs, but they created a really clever financial incentive for hospitals to join the network. And then finally, states that adopt this should minimize patient cost shifting, right? You don't want to say we're only going to pay this much and then all of a sudden have your patients be charged tens of thousands of dollars for still going to an in-network hospital, right? And so one way to approach this is just to refuse to contract with the hospitals that don't accept the reference rates. But even if you do, you should really intentionally communicate any of these changes in networks and payment ahead of time so that patients are aware of what might happen. Next slide, please. And then finally, this last report looked at 3 different ways that hospital practices can burden patients. And so we're looking at three of them here. We've got predatory debt collection practices and how that burdens low-income and marginalized patients. We have facility fees, which drive up the cost of care. Facility fees are basically fees charged by hospitals when they own a physician practice to theoretically cover some of the costs that they now have to comply with because they're owned by a hospital, but often just charged because they can. And then finally, the last one is private equity-backed healthcare providers manipulating surprise billing protections to inflate spending. The Federal No Surprises Act has done a really great job of protecting patients from surprise bills, but these providers have kind of manipulated those practices to still get a bunch of money, and it trickles through into premiums. Next slide, please. And so for this one, we've got kind of one set of policy recommendations for each of those three practices. The first one is to reform charity care requirements and debt collection laws. A lot of the times these patients that are being sent to collections by a hospital probably should have been eligible for some sort of discounted care in the first place. And so changing the way that states that hospitals have to provide discounted or free healthcare can prevent medical debt from accruing in the first place. But other states have moved to, bar medical debt from your credit report and change how hospitals are able to collect that debt. Similarly, states can just basically prevent hospitals from imposing these facility fees when they're not warranted. In addition to a ban on these fees, you can also require a different billing code from a hospital versus a clinic owned by a hospital, so that an insurer is able to say, well, hang on, this isn't a hospital, this is a clinic. I shouldn't be paying hospital rates if this care could be provided at a clinic. And then finally, the federal law that prohibits surprise billing allows states to figure out their own ways for figuring out how out-of-network providers should be paid. It sets a default, but states are empowered to do more. For example, California caps the out-of-network payments at 125% of Medicare's rates, or the average in-network rate for a region, whichever is greater. Maine is taking a different approach, requiring the people deciding what the rate should be to consider the in-network rate when determining the final payment, but without prescribing it has to be exactly this approach. Next slide, please. And that is it on those. There is my email and Jean's email if you have any questions or would like to follow up on these reports in more detail. And now we're going to move to our panel discussion. And don't forget to be putting your questions in the chat. All right, and I think there we go. Welcome to our panel. I will let them introduce themselves when they start speaking. But first, let's jump right into the questions. Secretary Kinsley, we'll start with you. North Carolina recently announced a first-of-a-kind medical debt policy using their Medicaid program. Could you share some insights to this approach and the waiver process there?
Sure thing. Thanks so much, Thomas. My name's Cody Kinsley, and I am joining you from a hotel room with a slightly blurred backdrop, a pink shirt, and a plaid, mostly blue blazer. It's great to be here. Medical debt, I believe, is a disease in our healthcare system. When we think about it, it accrues over time. We know that as debt ages, even just after a few years, providers broadly, hospitals particularly, rarely collect more than 5 cents on the dollar. They often tag that debt as uncollectible, and it stays on their books for a variety of reasons. And while that debt is rarely ever collected, and pennies on the dollar at best, the full weight of that debt still sits on the shoulders and the hearts of the people who didn't want that debt in the first place. In this way, I kind of think of debt both as a metastasizing disease and also maybe perhaps a self-licking ice cream cone. It kind of spirals because then people have the debt and they don't want to go to the doctor because they can't pay what they owe from the last visit. They delay preventative care. They end up in the ED, which in turn is a higher cost of care. So part of our higher cost problems in our country are driven by people not getting the preventative care that they need. And medical debt is a contributing factor of that. So North Carolina set out to tackle this issue with the tools that we had available to us. And we leveraged our state-directed payment program, which is part of our Medicaid program. Many states use these payment programs to provide essentially supplemental payments to hospitals to motivate a series of actions and to stabilize the health system and aspects of the health system. Many states put population health metrics or particular programmatic activities that hospitals have to do to get access to these state-directed payment programs. North Carolina decided to put medical debt policies as part of it. And so it was really two pieces. Retrospectively, hospitals needed to forgive debt for low and middle income North Carolinians dating back to January 1st, 2014. We've estimated that to be valued at about $4 billion worth of debt for 2 million North Carolinians. And then prospectively put in place a series of debt mitigation policies that will help prevent that debt from accruing in the future. The biggest piece of that being presumptive charity care. So if individuals are on SNAP or another public benefit that we know because of that benefit is income tested, then the person's on charity care automatically. And really for the hospital to take more responsibility of getting folks into the charity care programs that are part of their public benefits broadly. This has been a great process and it's rolling out and evolving. The last thing I'll say from a kind of more macroeconomic perspective is that we can put a lot of transparency into the health system, but when you have a heart attack and you show up in the ED, you're not going to shop around. Individual patients are going to take what's available to them. And as we think about consolidation and broader networks, choices are getting fewer and fewer. Insurance companies have the ability to negotiate in their rates and contracting processes. Government as payer gets to negotiate, but individual participants in the health system don't really get to negotiate. By capping how much patient responsibility will eventually flow into med debt, we put a little bit more of a finger on the scale of forcing collectively for hospitals to think a bit differently about rates that's going to drive up their prices. And while it's just one small piece of the puzzle, I think it is an important piece in the overall recipe of cost control.
Thanks. Definitely agree that it's important. Well, I don't want to cut anyone off if they have any thoughts to add there, but if not, we can move into. I have a question for Isabel. Colorado has really led the country in adopting, a lot of the pro-patient reforms discussed in these reports, but especially around the hospital practices like facility fees and surprise billing. When I was working on that report, every time I started on this section, I was like, well, let me go see what Colorado's done. Could you talk about your experience, advocating with the legislature to get these bills passed, and what lessons might be learned there?
Sure thing. Hi, everyone. Thanks so much for having me. My name is Isabel Cruz. I use she, her, they pronouns. I'm proud to be the policy director of the Colorado Consumer Health Initiative. We are a nonprofit, nonpartisan organization that seeks to ensure all Coloradans have equitable access to high quality, affordable healthcare. And I am sitting in a white and red room with kind of a colorful background of art, wearing a striped shirt, and really appreciate the attention to accessibility of this webinar. So building off of, I think, the great dialogue that Secretary Kinsley started around medical debt as a disease, I think a lot of the times we focus on the symptoms of some of these drivers in a policy, and that's the easiest things for people to see. We really have to get at the root cause if we want to eradicate the challenges folks have in accessing our systems. And so in Colorado, where I think we are affectionately seen to be the Wild West of healthcare policy, it has certainly been an interesting time throughout my 4 years here at CCHI to see what advocating for these things, oftentimes, which are first in the nation reforms, looks like on the ground. And I think the two policies that you highlight really show how the landscape has changed in the last several years. And so 2019, which was when our surprise billing protections passed after several years of working on that, was actually the first session in which Colorado had a Democratic trifecta. And so even though these healthcare reforms are nonpartisan, in my opinion, and I think work for everyone, it was really an interesting change, although I was not at CCHI, from what I've heard, with this shift to one-party control and what that meant about how healthcare policy was being made on the ground. But surprise billing was a bipartisan policy that pushed forward and was really supported by a little bit of an unholy alliance between us as consumer advocates and the carriers, the insurance companies, who had a real interest in making sure that they weren't the only folks blamed for these surprise bills, when really so much of the issue was the high prices that were being charged on the back end and how that was impacting folks who did not have a lot of, who had often had no choice in the care that they were seeking. And so that partnership to really highlight that issue and move forward to get at some of the drivers of these high costs and protect patients at the same time, I think was a really helpful way to move this conversation forward, and why we've seen some of the cost controls work a little bit better in Colorado than we've seen with how the federal No Surprises Act has moved forward. And I think then kind of going to facility fees in 2023, after many huge healthcare reforms had passed in Colorado that got very I would say spicy at the legislature, the tenor really shifted in who was willing to engage in some of these conversations, how we should push reforms forward. But at the same time, I think it really translated to folks what getting this seemingly, again, surprise fee looked like on the ground for folks. And so I think we really relied on working with, independent providers, select employers, and former hospital management folks who really got at the root of why these cost drivers and the symptom of consolidation was problematic for patients, to push things forward. And we were also lucky, I think, in both of these fights that there were some motivated reporters who really helped highlight the human cost of these challenges and move things forward when we see that, special interest, the healthcare is the top lobbied issue in Colorado in dollars. Really use that our session is only 120 days to try and sow as much doubt, as much fear about making any kind of change, right? And so having folks really at the front of this who were impacted by the issue on the ground was important to moving these pieces forward. And so I think, just to put a little bit of a picture of what this can look like for our facility fees conversation, we had a particular hospital's nurses show up to the hearing in shirts that say facility fees pay my salary, even though we have yet to see any evidence that facility fees are really the driver of paying for these staff. And so it's tough to move these things forward. It's tough to do things for the first time, oftentimes, but I think having a really strong coalition, having political will, and demonstrating the human cost, as well as cutting through what we've seen and why something like this report is so important as to how equity really is a challenge of costs, and actually charging people more money is not improving equitable access to care. It's stopping our most marginalized folks from getting access to care. And that is a really important point to move forward. I'm excited to continue to talk about it with you all.
Thanks, Isabel. Really hoping the rest of the country is going to be able to build on the first in the nation and follow y'all's lead a little bit. Well, Heather, I want to talk to you and give you a chance to chime in as well. Going back to the first report in this series, we've had around 10 states adopt these cost growth benchmarks, either through legislation or in some cases by executive order. Could you talk a bit about, what do we know about them? How can they be more effective? Are there other steps that states can do as part of them to make them better and advance health equity?
So thank you. I'm really pleased to join this terrific panel. I'm Heather Howard. I'm Director of State Health and Value Strategies at Princeton University, where I'm a professor. I'm joining you from a tan room in a hotel in New Jersey, and I'm wearing a blue shirt and a colorful beaded necklace and red glasses. And thank you, Thomas and Jean, for all the great work that TCF is doing. These reports are terrific, and I'm delighted. I'll jump in on the cost growth benchmark programs. As you mentioned, there are now 10 states, and the good news is that early reports is showing that these cost growth benchmarks, cost growth targets, sometimes they're called, can be effective at slowing the growth of healthcare spending, especially in the commercial market, which has been so troubling, as you noted, Thomas, in your opening remarks. So Massachusetts was the first to start over 10 years ago. They established a statewide benchmark in 2012, and a number of states have followed. Their efforts are more nascent, but we have the most experience with Massachusetts, and they established a health policy commission that has the authority to monitor compliance with the benchmark. And they also have accountability mechanisms. And they, in the early years, the program had success. The spending rate was lower than both the benchmark rate that they had set and the national rate of growth. In subsequent years, spending growth exceeded the benchmark, but the state still saw average spending growth lower than the national average. So I would say successful even when it wasn't meeting their own, that the benchmark was having success in slowing that growth. Those other states, other 9 states that have established those cost growth benchmarks more recently. So those efforts are younger, but they're showing promise. And let me just highlight a couple that I think are interesting, and especially on the equity front that you so rightly call out. So Rhode Island has focused on improving health equity sort of at the core of its work on affordability within the Office of the Health Insurance Commissioner, which is unique to Rhode Island. Those of us who follow state health policy know they have a public health and health equity measures work group. So they set specific health equity measures with associated targets as part of their affordability efforts. So they're looking at childhood obesity, behavioral health, healthcare access, and maternal and infant health. And then they're going to be doing public reporting on those baseline and then going forward, those equity measures starting in 2025. So Rhode Island is sort of incorporating health equity into their public reporting. And I think, to me, that's one key lesson, is that you need to, Thomas has called out the importance of data collection and public reporting. You need to put equity at the forefront of that reporting. Another way that you can advance equity is something Connecticut has done, is Connecticut's mission for their healthcare benchmark steering committee. It specifically calls out advancing health equity and consumer affordability. So they're not just talking about affordability, equity is embedded in it. Within that, I would also point out that it's not just collecting data and being public about it, transparent about it, is how easy is that data to access. And Delaware earlier this year established a dashboard that is and it's an important tool for raising awareness and transparency about spending. And it's broken down by market and insurer level spending, so you can get into more details. Sort of finally, I would say it's important to engage and leverage community voices. So states that are thinking about instituting healthcare cost growth target might want to consider establishing an advisory board to inform the development of these benchmarks. So, at the beginning of your process, of establishing a way to involve consumers and making sure that people with lived experience are being engaged. And in doing so, too, making sure that when you do engage them, you provide them with the resources they need to fully participate, meaning that they're compensated, that their costs like transportation, technology, language access, childcare, all of that is covered, right? So it's not just checking the box, that it's really meaningful engagement, and recognizing that it takes time to build trust and lasting relationships, so that it won't happen immediately, and that you need to make sure you're looping back to your community partners, and so that they know their feedback is being used and implemented, or why it wasn't implemented, because that is part of the trust building process. So I think, Thomas, there's promise, and there's ways to do it that really can build equity in. And so it's exciting that 10 states have them, and I would hope we'll see more in the coming years.
Awesome, thanks. Yeah, I fully agree about specifically the advisory committee and really making sure people can meaningfully participate. This next question, I might pose it to Secretary Kinsley or Isabel. Both of your states of North Carolina and Colorado both have that notice requirement for healthcare transactions, but they don't necessarily have the approval authority. So could both of y'all or either of y'all talk about what the state is doing, where you might want to see further changes to the policies?
This is Cody. Both Isabel and I happily pointed to the other to take the first call, which is normal. Thomas, thank you. I appreciate this question. So we've had the notice requirement for some time, and it hinges in our Attorney General's office to do a review, and there's some influencing authority that role has in that process, but it is not really a gating process in North Carolina. And I think that this is an important reform opportunity, but I also think that taking a step back, one of the questions that I have been wrestling with is, what are the broad systemic drivers? I think it's easy to demonize certain aspects of the system in this process, but as your slide elegantly pointed out earlier, this is not particularly unique to any one state. We're seeing national action in this direction. I think your point was 8,000 to 6,000 hospitals dropping over time. And so I think the gating process of approvals will drive, throw some sand in the gears, but I think that, it's going to take some other continued transparency and reform to try to diversify the marketplace in this space. And perhaps even more concerning than hospital mergers are kind of the vertical integration around providers and every other aspect. Healthcare is so much more diversified now than it ever has been. When we think about rural health in particular, hospital at home, various modes of care, what the future of health looks like is probably not hospital necessarily. And so it's I think the continued diversification of the marketplace to promote competitiveness is really important. And I know that that's been a key goal of our General Assembly in North Carolina. Their primary lever in trying to influence that space has been certificate of need reform. North Carolina, I think, had the second most issues subject to certificate of need in the country as far as its process. It's, I don't think, a perfect solution to allow more entrance into the market, right? Not everything is categorically needed, but it is an element of the driver. So I think it's, gating, certificate of need, competition, diversifying payment efforts, and then other consolidations that are going to be hard here. The last thing I'll say in this point, oh, maybe I'll save it. I'll pause there. Over to you, Isabel.
Thank you. This is Isabel. And I think you brought up a lot of points that feel very relatable here in Colorado as well. Similarly, there are controls and means for our Attorney General to ensure that, particularly nonprofit to nonprofit mergers, that the charitable purpose is carried forward with any merger for hospitals. And there is kind of consideration for whether there would be reductions in the availability or accessibility of healthcare services in the communities served by the hospital. However, we haven't necessarily seen on the ground that the laws that we have on the books are potentially creating the results of creating conditions or putting more scrutiny on some mergers that do have some real concern about consolidation and access to care for people. I think, as was mentioned in the presentation, particularly in our rural communities, there has been concern about access to reproductive services as faith-based hospitals have been growing their reach in rural areas. Additionally, there was a merger a couple of years ago between SCL Health and Intermountain Health, some major hospital systems, and now Select Health, the insurer that's associated with Intermountain, is also now in Colorado in the last couple of years, right? So there's some mounting market pressures that I think is really growing consolidation in this state. And even though we have seen and really do appreciate that AG Weiser in Colorado has taken on medical debt as a key issue during his time in Colorado. There has been a little bit of a mix of potentially not enough authority, but then also less motivation around consolidation in this space. And so we hope that moving forward that there will be greater tools. I think this is a space where we're looking to some other states that are leading on this, like Oregon, for how do we ensure that mergers are, one, not having a negative impact, but two, are having a positive impact, right? And as Secretary Kinsley was talking about with the different kind of levers in this, what we're seeing, and through the Facility Fee Steering Committee work that we did, in which a rural hospital CEO was on, he raised a really good point that you talked about, Thomas, in your presentation, that there is an equitable payment across different providers. And these mergers and acquisitions don't get at the root of that, but are part, right, of this inequitable payment is part of why so many rural practices in Colorado, particularly in that vertical integration space, are being sold to larger systems. And so we're hoping that that's some more information we can get with future reforms on our mergers and acquisitions, but also how can we get at the root of making sure that folks are equitably paid for services across these different systems and disseminating the market power of some of the bigger actors in the state to ensure that we have a healthier market. And so that's going to take a lot of pieces, and we are hoping that the mergers and acquisitions piece, improvements in that in the next couple of years will help.
Isabel, if I can just chime in and riff off, this is Cody, riff off something you said. North Carolina, like a handful of now remaining states in the Southeast, was late to the game on Medicaid expansion. And I think that, is a key enabling factor for why we saw this kind of have and have nots, right? If people living in rural communities were 3 to 4 times as likely to be uninsured, then the rural hospitals serving those communities were having 3 to 4 times as many people walk to their front door without an ability to pay. And that piled up into debt over time, as we discussed earlier, but it also made the financial dynamics, add on to this workforce recruitment issues, broader ability for individuals to live in some of these communities, turned into a situation where these rural hospitals were really struggling, in which case, the choice often became, do we merge or close? And that also makes an impossible choice for any of these gating considerations. So I think it's important, again, we think about the levers, but the kind of symbiotic nature of these pieces of the puzzle, and that we just can't, squeeze one part of the balloon so hard. We got to kind of move all the pieces. And that's been part of North Carolina's strategy, which is, how do we increase access to coverage? How do we try to use our Medicaid dollars in a way that is preventative and get upstream by investing in social determinants of health? How do we also use our other foundational human service programs like SNAP and WIC, to promote health overall? And then how do we continue to push towards value-based payment and outcomes as opposed to just paying for more? And I think those incentivizing strategies invites more people into the market, invites competition, and continues to keep the marketplace rich and diverse. And hopefully that helps support a reduction in price too.
Thank you both. This is Thomas again. Well, Heather, I want to turn to you for maybe the last of the questions that's kind of directly related to these reports, and then we might move into some more future-looking stuff as we close out. But reference pricing, is one of the strategies that is a little less adopted compared to some of the other ones we've discussed. Do you have any insights why that might be, or any thoughts to share there?
Sure. I mean, I think quite frankly, it's because it's harder. And I think we ought to think about all these strategies we were talking about as existing on a spectrum, right? And it depends on how aggressive or muscular a state can be, wants to be, and can be. And so this one is harder. And I think it's important not to we can't discount the role that politics plays in these decisions. And providers are not excited about what they perceive as government setting or capping prices. I'm struck by Isabel's comment earlier that healthcare is the top lobbied issue in Colorado, and I would bet that's true in North Carolina and every state in the country, right? So, I mean, we know it's close to 20% of our economy. So I'm also struck, Isabel mentioned that they formed what I would call strange bedfellow coalitions to advance your pro-consumer reforms in Colorado. And so I think today, the examples cited from California and Oregon are exciting, and they're proof of concept that this can work. But it's also a reminder how high rates are in the commercial market, that they could settle on reference prices that were twice Medicare rates and achieve savings. But the silver lining I see here is that, in my experience, states are willing to try new things when there is that proof of concept and there's that competitive pressure among states. And so when there's a successful model, that can gain traction over time. And so these models, I think, could be models that states could look to in the future. But I think it's important to call out that this is that this question of provider power that we've been dancing around in several of our answers is particularly salient here.
Thanks. This is Thomas again. Yeah, I think we're going to move to maybe a little bit more future looking. Looking at the time, we're coming up on 3:00 Eastern here. And so I might just pose, a similar question to all three of you, and you can, look at the federal government, you can look at the state government, but what are some changes you're hoping to see, over the next year or two, again, either in your state or at the federal level to make healthcare more affordable and more, equitable. And I'll let whoever wants to go first start.
Well, I'll start since I've noticed nobody. This is Cody. I've noticed nobody else turning off their mute. Clever. So I want to actually jump with something that I think, Thomas, you mentioned earlier, maybe Heather, it was you, but we have to start with the data, and I think that's really, really foundational. And in some circles, equity has unnecessarily become a bit of a bad word. There has been kind of this pushback on the frame, and I think that folks in the health space are particularly well equipped to push back on this. We have a long history of looking at and understanding health disparities, and we've built a coalition of folks that understand when we talk about health disparities, we mean Black, in North Carolina, I'll speak for that, Black mothers dying 2.5 times as often as white mothers. Individuals in rural communities, as I mentioned earlier, having disproportionately larger lack of access to care and lack of insurance coverage. We think about the impact of poverty. I often like to think that poverty and serious mental illness are co-occurring issues, and I think the ability to really center ourselves on the data and then use that to drive a lot of our implementations matter, and most importantly, to drive a coalition of folks across rural, impoverished, race, ethnicity, and a number of other qualifiers across it. We just put out a report that aims to do this, which is, breaks down this in a variety of ways. And then I think from there, driving the conversation towards, well, how do we continue to pay for more of what we want, which is healthy people, right? And this is the big thing, right? Like, the original sin in healthcare is that our system is fee for service. period. Makes sense at the hardware store, not so much when there's so many things that could be done in healthcare that don't drive health, and when fee-for-service is there. And so, I think there's big questions that need to be had about what does the wholesale transformation look like. We've blinked, and now many government programs are running through managed care companies, right? That we've kind of head faked our way into, managed care, Germany-based model kind of health insurance almost to a degree. But I think we still have to wrestle harder with the fee-for-service issue, because unless we can figure out a way to truly disrupt that beyond just value-based care, we have a lot of pilots maybe really disrupt that, then a lot of these other systemic things I think we're not going to be able to unpack.
I'll jump in. This is Heather. I'll pick up the baton from Secretary Kinsley. That although the challenges seem daunting, I think what we've highlighted today are exciting opportunities, right? And so, for example, on medical debt, it's worth going back to reiterate those first principles that we know medical debt has significant equity implications, that it has a disproportionate impact on low-income communities, those states that have not expanded Medicaid, and particularly for Black and Latino populations. So these exciting medical debt initiatives across the country, we count 7 states that are that have initiatives to cancel medical debt. What North Carolina is doing is going even beyond that, going upstream to then try and address and prevent the accumulation of debt. Minnesota recently banned healthcare facilities from denying care based on owing debt. So you've got a lot of great stuff happening on medical debt. Then also just on costs more generally in the commercial market, we're seeing states that have their own marketplaces are using state dollars to provide additional financial assistance on top of the federal assistance. So I think we're seeing that states, even when those of us who do state policy always worry about state fiscal constraints, we're seeing states innovate even within those constraints. So to me, I think of it as an exciting time because we're seeing all this innovation.
Great. That's a great segue for some of the things that were coming up for me in this conversation thus far. A lot of times I hear the states are the laboratory for a lot of the policy that moves at the federal government. And I think what's really important for all of us state folks to acknowledge is, we can only impact a certain portion of the population with the state policies we pass on coverage. And so, continuing to look to our federal counterparts to push some of these reforms forward, I think is really important so that all folks in all of our states have, some of the protections that we've been able to build in at some of the state levels, like kind of where we started with surprise billing and where we've gotten with the No Surprises Act, even though obviously there's more to go. And on that, I think something we're really excited about that's going to be moving in Colorado next year, but also hoping at the federal level on closing some of the loopholes on ground ambulance billing. That's a continued pain point for consumers we see on the ground. And those balance bills, when very few Coloradans have more than $500 for a surprise bill, I think those bills are a huge point of concern. And I think also we've been having a lot of conversations as a state about the viability of our particularly rural emergency medical services. And so I think this is another important place for rural healthcare access, and also making sure that we shield our lowest income folks from big bills. So I am excited for us to work on that in Colorado, and hopefully with the committee wrapping up at the federal level, there might be some movement there. We'll see. And I also wanted to say, right, like, there are so many places that we can make a difference in equity when we lead from an equity lens. All of our policies have to lead from an equity lens of who is the most impacted. Are those people at the table when we're talking about the policy design? And does it make sense to them, right? Because I think something that we're still working on the ground is medical debt issues make sense to people, but we still have a lot of work to do as advocates to connect the dots for people as to why healthcare costs so much and how market consolidation has a role in that. That we're not there with people on the ground. And I think that that's really important to continue building political will for these really important policies. Yeah, I think with, leading with a race class lens, we can make, really impactful changes, like with our Colorado option at the state level. We've heard so much feedback that creating a standardized plan design that led with, increased coverage for perinatal care and for diabetes coverage really has made a difference for, Black and Latino populations that are disproportionately affected by diabetes, right? And who do have some who are challenged, right? Not only in mortality, but also in getting respect and getting the care that they need in the perinatal period. And so I think that there's so many opportunities. It's such an exciting time, I think, as both of you highlighted, and really hope that in this moment in which I think there's so much awareness about the challenges in our medical in our healthcare system, that we can really move some exciting things forward to get at some of the root causes of these problems for folks.
This is Thomas again. Thank you all so much. I think what you were saying, Secretary Kinsley, about equity being a dirty word these days in some circles really struck me. We don't all feel the burden of high prices in the same way, and so it feels silly to me that we might, that people think we might all have the same solution to how we feel those burdens. Well, I know we are right on time, so I will just reiterate, thank you all so much for attending. Thank you to our speakers for participating, and thank you to our ASL interpreters and CART for helping ensure this is an event that everyone can attend. Have a good day, everybody.